So in 15 minutes, I'm going to discuss how we diagnose CFS and also talk a little bit about some of the treatments that we offer. And hopefully, I can skip some of the slides because we've already discussed them. For instance, you all know about the CDC definition. This usually comes with a lot of noise, which thankfully is not going to be played. But we've all discussed about post-exertion malaise, and we know about non-restorative sleep, etc. So I can skip this lot here and get on to some of the exclusion criteria. And these have been also mentioned in the CDC criteria in terms of excluding any medical condition that can be associated with fatigue, any sort of psychotic, melancholic, or bipolar depression, dementia, etc., etc. But then later on, further sort of exclusion criteria were provided by Reeves in terms of organ failure, chronic infections, rheumatic and chronic inflammatory diseases, neurological problems, disease requiring systemic treatment, etc., etc. But I think what we need to appreciate from this is that people who have recovered from organ failure may actually go on to develop CFS-compatible symptoms, ME-compatible symptoms, as may also occur with chronic infections. So although these are exclusion criteria, in the long term, I think we're going to have a very narrow range of conditions which produce lifelong exclusion of possible ME. And then there are lots of temporary exclusion criteria which are indicated here, and further ones here. And then to try and bring things forward, and to try and simplify things, we've got the ME-ICC criteria, but far from simplifying things and allowing utilization of a simple set of criteria for clinical purposes, we now have a whole sort of list of, you probably can't see the arrow on there, but in addition to your post-exertional neuroimmune exhaustion, they call it here, you've got additionally patients must have at least one symptom from 3 of the following 4 neurological impairment domains into neurocognitive impairments, difficulty processing information, etc., etc. And then patients also must report at least one symptom from 3 of the following 5 immune, gastrointestinal, genitourinary, urinary impairments, flu-like symptoms. And then final category down here, number 4, is energy production, transportation impairment. So it isn't simple, actually. And what we really need are a simple set of criteria that we can use and which can be used by clinicians in general practice, in secondary care as well. And then if we look at the Canadian and the ME-ICC criteria versus all the others, including the FUCADA, then in general we find that the subjects that fulfill the Canadian and the ME-ICC criteria, they tend to have greater functional disability and more severe symptoms, especially neurocognitive dysfunction. And then, if we look at the Canadian ME-ICC criteria, they're also better able to identify those with true CFS-ME rather than idiopathic fatigue. However, the ME-ICC tended to select patients with greater psychiatric comorbidity, and the Canadian criteria appear to select the lowest rate of false positive in those with depressions. So useful. I mean, we use the Canadian throughout all our work, and they appear to be very helpful in excluding people who have major depression. And then if we look at ME versus CFS, I mean, there's a lot of controversy. In this country, we've tended to use CFS quite a lot, and I know that lots of the patient groups prefer the term of ME. But what is the difference? Well, ME patients, from what we can gather from the literature, have been considered to have a more consistent and significant post-exertion malaise. The ME patients have more neurocognitive dysfunction. And fatigue and the other symptoms more frequent and severe with those in ME. And then we're going to talk a little bit about the DePaul symptom questionnaire in assessing the frequency and severity of the important symptoms. So we want to try and operationalize some of the criteria that we have. And this is what we tried to do in the Sutton service. And so a while ago, when I looked at all the different sort of criteria that were available and allowing me to determine very quickly which patients would actually have true CFS-ME, and in turn to allow the nursing staff and the others to try and diagnose this condition more easily, what I decided to do was look at the criteria and see whether we can have some sort of scoring system. And this is what this is meant to indicate. So The most important symptom, as we mentioned on several occasions now, is the delayed post-exertion malaise. And really, we see it both after physical, mental, and emotional excess. The non-restorative sleep with difficulty initiating and maintaining sleep is very important. But for the delayed post-exertion malaise, if they has a true set of criteria, then we give them 3 points. For the non-restorative sleep, 2 points, and then the impaired concentration, that is reduced further by external stimuli, 1 point. And you can see we can go down all the sort of main sort of symptoms that we see in people with CFS-ME. And the total comes to 13. So in this scoring system that we have, you need to have at least 8 or more from 13 points to confirm CFS-ME, with an absolute requirement for some form of post-exertion malaise. They must have that. Now, the delayed post-exertion malaise gives 3 points, while there are a subgroup of people who have an immediate post-exertion malaise, and that gives 2 points. And then an immediate post-exertion malaise of less than 3 hours duration, that gives 1 point. And the fatigue, neurocognitive problems, myalgia, arthralgia, hypersensitivity issues, they must be significant. This is the important part. They must be significant and cause disability for more than 50% of the time. The sleep disturbance, as I said, is very, very important. Non-restorative sleep impacts significantly on fatigue. And the presence of both, the impact that the sleep disturbance has on fatigue, that will give you 2 points. And it must be present for 5 or more days each week and persist with the hypnotic. We have a number of people who use zopiclone or agents that help them get off to sleep. But what they do say is that despite taking these agents, they still feel tired in the morning. And then the sore throat and the flu-like sensation, they must be present for more than 1 day a week. And then the neurocognitive dysfunction with impaired concentration and memory problems, it's aggravated by overload from excessive visual and auditory stimuli, which is what I'm sure lots of you recognize anyway in terms of when you go out to crowded areas where there's lots of lights and sound, you find that you can't really think properly. We're always very careful when we have patients have significant anxiety and depression. However, we do note that depression and anxiety can complicate CFS and also the other way around. But in our research studies, although I've said you need to have at least 8 out of 13 points, all our patients who are entered into research will have 10 or more points. And we exclude those with significant depression and anxiety. The HAD scoring system is partly helpful in this regard. I've also indicated some very interesting things that we've noted in the hundreds of patients that we've seen, and that is that hypersensitivity to medication is particularly frequent, and especially to the SSRIs, SNRIs, and the tricyclic agents. The other thing we've noticed is that alcohol intolerance is very frequent, and tolerance of 4 units or more in a single sitting really makes us think, do these people have CFS? And in fact, what we've noticed is that fewer than 10% of our patients continue regular alcohol ingestion. I'm not sure if that's true. But from our own work, that's what it seems to suggest. So from a clinical perspective, and there's some additional things that we look for, not from a research perspective, the additional points that may help in suggesting the diagnosis in borderline cases, and these are some of the things that you may also notice, cold peripheries. I mean, very frequently when I shake hands with patients as they come in, their hands are cold, and they'll say their hands and their feet are very cold. And this is more evident in those who have moderate or severe CFS, less so in the mild cases. Alcohol intolerance, drug hypersensitivity, and altered pupil reflexes and a sighing pattern of respiration. We also look at that, and if you have 3 or more of these 5 features, that will give you an extra 1 point in helping to make the diagnosis. Now, the altered pupillary reflexes is something that we've noticed for about a year. If you shine a light into somebody's eyes, their pupils constrict. And that's pretty obvious. I mean, that's the normal light reflex. But what people don't do is to keep the light there. And if you do that, if you keep the light shining, what you notice is that the pupils will start to constrict, dilate, and whether that's important in the hypersensitivity to light, we're not sure. But it's very interesting, and it seems to be present in at least 60 to 70% of patients. So what about CFS and depression? Well, there are certain things that seem to indicate whether depression is the main cause of the fatigue. So those with ME often have adverse reaction to antidepressants commencing normal dosage, and that happens very frequently. The pattern of sleep disturbance is different. People with ME find it difficult to get up in the morning, while those with depression have early morning awakening. In general, that is, ME sufferers can start a task but have difficulty finishing it, while those with depression find it difficult to initiate the task, but quite often once they've started it, they can finish it. And then the ME sufferers don't tend to resort to alcohol, while some with depression do. We're always, as I said before, care with using the criteria to check for CFS in those who have significant depression. Now, the conditions that can mimic CFS-ME we're very, very careful about in all our work, and these are indicated here. Joint hypermobility we're seeing in about 20% of our patients, and I don't know how that produces the fatigue symptoms, but it's very consistent. We're also, when patients are referred to us, we make sure that the GPs check their thyroid function and also their urine electrolytes and a whole series of other things. Sjogren's syndrome, I have found, probably in about 10 patients who were referred with CFS. Early PBC and Julian Newton would have talked about primary biliary cirrhosis, but it's very interesting that fatigue is a major component of many of the connective tissue disorders, and it may well be that if you have a connective tissue disorder, you have autoantibodies to other receptors, neuroreceptors, that may be involved in mediating fatigue. All our patients will have a check for gluten sensitivity, and we're very careful about persistent anxiety as a generalized anxiety disorder and depression. Primary disorders sleep, we use the Epworth Sleep Scale for that. And then occasional patients, in my experience, have had cardiac dysfunction, Parkinson's disease, and temporomandibular disorders. And here are the common set of symptoms. I'm sure you all know these. The physical signs are very interesting. We see pharyngitis and lymphadenopathy in the anterior and posterior cervical regions, sometimes in the axillae and the temperature. But the other thing we have noticed, and we're doing a lot more work on this, is that a number of our patients, most of our patients, will have a mildly increased respiratory rate. And it's very interesting that there is an app available for the Apple iPhone and the iPad, which allows you to measure respiratory rate. And the respiratory rate, inexplicably, is elevated by about 10%. The cold peripheries I've already mentioned, present in about 70%, and the altered pupillary reflexes in about 60%. So what are the investigations that we do? These are indicated here. Without these, we won't accept a referral from the GP. But then there are a whole series of other investigations that we think about doing. If there's evidence of a connective tissue disorder, then we'll check for antinuclear antibodies and the ENA and DNA antibodies. If there's any suggestion of a synovitis, then rheumatoid factor and CCP. We check for muscle tenderness, muscle dysfunction, and muscle damage with these two enzymes. Sometimes go on to an electromyogram. Very careful about the presence of osteoporosis, and arrange a DEXA scan if it's appropriate, because we know that osteoporosis can be associated with muscle dysfunction and in fatigue. And then Cushing's syndrome, synactin tests, etc., etc. There are highly specialized tests which we'll arrange occasionally, but at this stage you've heard a lot about NK cells, about T cell subsets, B cell subsets. At the moment we don't do this on a routine basis, but we do a lot of immune-based work on our patients. And the same goes for these sort of tests here. In the future, I suspect these may well be helpful, not as single tests, but as different sorts of tests, collections of tests, which will allow us to help to make the diagnosis. At the moment, we don't really test for many of these things because we don't really have treatments available. So finding out if somebody's got EBV or CMV would be very interesting. It helps from an etiologic point of view, but in terms of treatment, it doesn't help us at the moment. I suspect it will do over the next several years when we determine what the true role of these agents are. And the same goes for these other agents here. And triggering factors, again, very interesting in terms of life events, physical injuries, and environmental toxins. And we've already heard about organophosphates in the Gulf War syndrome. Childhood traumas have been discussed in the literature, but again, we don't delve into these because I don't think it really helps the patients at that point in time that we see them. And then treatment. I've just summarized what has been used. The pacing, graded exercise therapy, CBT, that's all recommended under the NICE guidelines, as is mindfulness meditation, breathing control, etc. And these are also suggested as well. And the GABA agonists in particular can be helpful for peripheral pain. Now, vitamin B12, we have found that helpful, but it says in the NICE guidelines, don't use it because there's no evidence. However, we have done an audit of our results in using this, and it appears to help, particularly the cognitive function side of things. Vitamin D3, all our patients are low in vitamin D3, and we put them on replacement therapy. Only a very small proportion improve. Muscle tonics, magnesium, L-carnosine, coenzyme Q10, we've heard that the levels of some of these may be low, and replacing them helps a small proportion, perhaps 5% of patients. Modafinil, naltrexone, nimodipine, you've probably heard about some of these in various small trials and anecdotal reports. Modafinil has found it helpful in 1 or 2 patients in whom it improves their ability to focus on tasks. Melatonin we use quite a lot for sleep, but we haven't used a lot of these at the moment. Chinese herbal treatment, again, anecdotal reports. Immunoglobulin therapy, I think, does hold promise for the future. I've made 3 or 4 applications to our Drug and Therapeutics Committee to use this. They've been declined because they say there's no evidence for their use and they are very expensive. But I think this really holds promise for the future. Same goes with antivirals, antifungals, and antibiotics. Ampligen, if we had more time, we would talk about that. And of course, anti-B-cell therapy is something we are actively investigating with the rituximab trial. So there are lots of agents available, but unfortunately in this country, NICE really looks only at those agents over here. I'm going to leave it at that. And
Thank you very much.
Great.
I have a question from somebody who asks about beta blockers, your opinions on beta blockers and nimodipine, which you mentioned there. You were saying kind of for some people and not others.
Well, beta blockers I do use in people who have a lot of anxiety. I mean, CFS can generate anxiety when people don't know what the cause is. Yeah. It's unpredictability. But if the anxiety gets on top of things, it can really delay progress and improvement in those situations. And if there are no contraindications, then a beta blocker can be helpful.
And the other one is the psychosocial view of ME is dominating the decision-making processes at NICE, DWP, and D of H. How can you make sure these institutes take the scientific findings into account in their policy making?
Okay. I've been saying this. Okay.
That's an unfair question, I think, unless you.
But let me answer it very, very quickly. Actually, I think what we need is a very big trial, a very big piece of research, employing 300 to 400 patients, and what we need to use in that trial is all measures of sleep disturbance, their level of physical activity, stress levels, depression, anxiety, and then to look at all the things that we've been looking at earlier in terms of NK cells, cytokines, various metabolites. And by doing the various sort of clever statistics that are possible, to be able to say at the end of it, we know that these variables are increased or decreased, and we've excluded the possibility that these changes may be due to depression, may be due to anxiety, they're not caused by disturbed sleep or inactivity. And I think it's only once we've done that trial and it's published in a leading journal, I think that we'll make progress.
And the other question then I'll ask somebody called Saul Berkovitz, who's not going to have the chance to sit on the panel, but he might have a view about some of the things that you've been talking about. That is, somebody asks about their daughter who's bedridden and who really is in pain when the damp, wet, windy weather appears, and they ask specifically the question about a mold, a relationship to a mold.
Yeah, there have been I've seen one report at least on the role of mycotoxins and fungal infections in perhaps causing CFS. It's interesting, but it's had only a limited number of patients, and in one individual who had very significant ME symptoms and who also had nasal carriage of a mold because they had recurrent sinusitis, they did offer treatment with fluconazole for a fairly long period of time, but it didn't seem to make a difference. So that's my experience of N equals 1.
Angela.
Just a brief question, because from my ignorance, I'm sure, but have you done formal sleep studies on these patients with polysomnography? I mean, is there really a sleep pattern? that,
Yeah.
that would be classical for this disease and
there's no-
excludes other
Sure.
forms of sleep disorder?
There's no classical pattern, but people can have difficulty initiating sleep. There are changes in the different phases of sleep. But what the reports tend to show is that there's no consistent pattern between the different series. We do know, however, that when patients wake up, that they don't feel refreshed from their sleep. That's the most consistent thing.
That's a very good test, personally. See, as you get older, you never feel refreshed.
Yes, sir.
You talk about excluding on the basis of primary sleep disorders, but there's a bit of a horse and cart relationship with sleep apnea, because many people would say that their sleep apnea came after their ME. I would certainly say that.
Yeah.
And
I mean, the thing there would be to obviously do the various studies and to offer the CPAP therapy and see if patients improve, if the person improves afterwards. And if they don't, it's likely that their primary problem is CFS-ME, but they have an additional problem with sleep apnea.